Hello, my name is James Enoch, and in this presentation I'll be discussing inner ear infections, known as labyrinthitis and vestibular neuritis. So what are these conditions? They are infections that cause inflammation of the inner ear, usually resulting from viruses, bacteria, and some other specific causes that usually affect older adults from 30 to 60 years old, unlike outer or middle ear infections, which are much more common earlier in life. However, these diseases are also closely related, which I will discuss later on. The reason why that I wanted to discuss these conditions and why I think it's important for any clinician to be aware of is because these conditions can mimic the same symptoms as other more serious conditions, such as cerebrovascular accidents like a stroke or a heart attack or other life-threatening conditions common to this age group. So what are the affected structures? In labyrinthitis, we see inflammation of the labyrinth, which is basically the structures of the internal ear, including the semicircular ducts and the cochlea. The semicircular ducts are very critical for vestibular function, so balancing, and the cochlea is important for auditory functions. And in vestibular neuritis, the cranial nerve 8 or the vestibulocochlear nerve can also be inflamed, which can cause just very severe disruption of normal auditory and balance for the affected patient. So for the common causes, the most common cause for labyrinthitis is a viral infection secondary to an upper respiratory tract infection, or possibly also from a secondary infection to the outer or middle ear. It's the most common, but it also happens to be the least well understood of how exactly it begins to affect the internal structures of the ear. However, we do know that infection by herpes, influenza, measles, rubella, mumps, hepatitis can all spread to the inner ear, resulting in labyrinthitis. And one key finding in a study was that labyrinthitis secondary to maternal rubella infection is one of the most common causes of congenital deafness or deafness from birth. So this disease can have some long-lasting effects if it occurs in young age. However, that is less common. Bacterial infections of the inner ear are less common, but may lead to more serious infections because of their difficulty in treating. Typically, it will spread from otitis media infections, and in serous labyrinthitis, toxins produced by the bacterium will spread into the inner ear or possibly the semicircular canals, causing irritation, inflammation. In suppurative labyrinthitis, the bacterial agents themselves will cross into the inner ear, and this is more typically seen with a primary infection of the cerebrospinal fluid or bacterial meningitis, which obviously those are extremely dangerous conditions in and of themselves, but when the inner ear becomes involved, they can become even more likely to cause lifelong comorbidities. So let's get into the symptoms and signs of labyrinthitis and vestibular neuritis. There are typically two phases of presentation, the acute phase being the initial 72 hours after the infection. And typically, a patient will experience extreme sudden onset of very severe debilitating vestibular symptoms. And typically, this will be the first indication that an inner ear infection is present before any type of ear pain or other signs like that. They will experience abrupt dizziness and vertigo, typically even with visible signs of falling over or unsteady balance, tinnitus with hearing loss on the affected side or possibly both sides if it's bilateral infection, loss of balance, and nausea and vomiting with the extreme vertigo that is induced by acute infection. It can cause the patient to feel so off balance that they begin vomiting. And after the initial 72 hours, the chronic phase that follows usually lasts around 2 weeks, but has a slight chance of lasting even longer. And these vestibular symptoms are typically less severe than the initial phase, but still bad enough that they would interfere with typical activities of daily living. So chronic dizziness, especially when traversing public spaces or environments that the patient is not familiar with, or just involve a lot of peripheral motion, like with driving or any public space where there's a lot of people moving around, like a grocery store. Another commonly reported symptom in this chronic phase is just the feeling of disorientation or brain fog, simply feeling unwell without very specific ways to describe the feeling of being unwell is what patients will often report. And this sort of mirrors our experience as athletic trainers with patients post-concussive syndromes. They typically also will report similar symptoms of just feeling off and not being able to think as clearly as they are used to. So what are the steps that a clinician can take to diagnose inner ear infections? The history is probably the most important part here because of the importance of differentiating it from other more severe life-threatening events like a stroke or heart attack. A history of infection is going to be really critical in identifying this condition early, because patients with a history of chronic outer ear or middle ear infections are more likely to become affected by an inner ear infection. Some physical exam components that could be used in a battery of testing to identify this condition would be the Romberg or tandem gait test for nystagmus, which might be more useful in the chronic phase, because in the acute phase, the patient's loss of balance will be readily apparent upon presentation. The Weber hearing test, typically conducted with a tuning fork for sensorineural hearing loss, would be an effective way to identify tinnitus or lasting hearing loss that could be, again, in the chronic phase, resulting from an inner ear infection. Otoscopy might also be included because of the chance of a primary infection of the outer or middle ear with secondary inner ear infection. So identifying inflammation of the outer structures and examining the tympanic membrane for integrity and redness, inflammation, the presence of pus and other immune activities. Asking the patients if they've experienced tinnitus, which may be present with, more likely present with labyrinthitis versus vestibular neuritis. So differentiating between those two, as well as other bacterial lab tests for the co-occurrence of meningitis, which is, as we discussed, is also a common co-infection, as well as a history of autoimmune disorders. And there is some evidence that certain autoimmune disorders can begin to cause inflammation at the sites of the ossicles in the inner ear, which can lead to similar symptoms as an infection. Now we'll discuss some treatment options for the patient that has been diagnosed with labyrinthitis or vestibular neuritis. In a viral infection, hydration and electrolyte replacement and rest, monitoring for the symptoms are probably your most important treatment factors. There's little that can be done to directly address the infection, save for waiting for the body's immune response to kick in, and basically supporting that while the patient recovers from the acute phase. However, there are some options such as antiemetics for severe nausea and vomiting, causing the patient extreme discomfort, as well as antihistamines and possibly other medications such as benzodiazepines for the initial vertigo. However, it's recommended that these medications are only administered on a very short course because of the high likelihood for lasting vestibular deficits if these medications are used to treat the acute phase for too long. In bacterial meningitis, when the infection of the inner ear is secondary to a middle ear infection, it's important for antibiotics to be administered through eardrops into the outer ear canal, because treating both sites of infection are going to be important for fully recovering from the disease. However, if there are systemic symptoms, and this would be a high indication for possibly other systemic infections like meningitis or an infection of the cerebrospinal fluid, oral or intravenous antibiotics would be a more expedient way to treat the infection, depending on the severity of the patient's symptoms and if they're likely to develop other infections because of some other immunosuppressed state that they may have, or other causes. If the patient has an autoimmune disorder that is causing the inflammation at the inner ear, these are treated with corticosteroids or other immunomodulators that are typically used for autoimmune conditions that cause inflammation at other sites of the body. But the important part here is that we're treating the symptoms of the inner ear infection or the inflammation at the inner ear more than treating the autoimmune disease or condition itself. So monitoring for the symptoms after the administration of these drugs is critical. When we get into the chronic phases of the inner ear inflammation, it's important to understand that treating the symptoms with drugs is probably not adequate, because vestibular deficits can lead to lasting compensation for poor balance. So any patient that is experiencing chronic symptoms would be indicated to be referred to a ear, nose, and throat specialist for vestibular therapies. And these can include balance activities, other neuromotor control activities that we would typically use for rehab and coming back from a concussion, and biofeedback aids in establishing a proper head position, and hearing aids that may assist with the chronic tinnitus that infections of the inner ear can also cause. So what are the outcomes like for this condition? Most individuals have a good prognosis, and the symptoms will fully resolve within 2 to 3 weeks after the infection either is cured through antibiotics or is simply fought off by the body. However, there is a chance that a lasting impact may be made. Bacterial meningitis, while it is known to be a cause of inner ear infection, can also result from an inner ear infection. And in patients that experience a lasting infection of this nature, they may have effects such as bilateral vestibular hypofunction, which basically means a decreased ability of the structures of the inner ear to communicate with the brain and centers of control for balance and coordination. So this can be extremely debilitating and will require lasting rehabilitation that allows the patient to establish a good amount of motor control, and so that they're able to complete their usual activities. Hearing loss and even complete deafness may also occur resulting from the bacterial meningitis infection. And if there is hydrocephalus, or basically a swelling and liquid in the membranes surrounding the inner ear, the patient may require shunts, or basically a drainage of those structures. And that process may take a series of visits over time, even after the infection is resolved, because it can be recurrent. In bacterial labyrinthitis, so a direct infection of the labyrinth with a bacteria, basically the suppurative form of bacterial labyrinthitis. In certain cases, the ossicles of the inner ear inside the labyrinth itself may become excessively calcified and harden, and this can lead to lasting auditory deficits, similar to congenital deafness. And this can be a lifelong condition that really doesn't have a clear treatment or cure. It may also lead to mastoiditis, which is an inflammation at the temporomandibular joint, or mastoid processes. And this can interfere with activities such as eating and speech, and so may require further antibiotic treatment to resolve. As we discussed earlier, another possible lasting outcome of this condition, if the patient is excessively treated for vertigo with medications such as benzodiazepines or antihistamines, it can actually delay the recovery of the vestibular functions, because of how those drugs can lead to overcompensation for the vestibular deficits. So that's definitely one thing that, as a clinician, we might need to educate the patient on, because they might desire more treatment than their body is actually that's actually good for them, and will be able to lead to a quick recovery. So in conclusion, it's important to be aware of this condition, especially in our middle-aged patients, because of its initial presentation similarity to those conditions like stroke and heart attack, where the patient may also be falling over or complaining of ringing in the ears, and just pain in the head, inability to control their nausea and throwing up, everything like that. As well as, it's important to understand the connection between the vestibular disturbances seen in labyrinthitis and vestibular neuritis, and the infection that is the direct cause of it, versus other causes of vestibular disturbances, such as head trauma, or other deficits of balance due to other conditions of the inner ear, such as benign paroxysmal positional vertigo, or other conditions like that, where the dizziness is there, but an infection is not the cause. So noticing other signs and symptoms of infection through otoscopy, or simply just questioning the patient on the length of symptoms and what provokes the symptoms, is important for a differential diagnosis. Another component of this that's important from our standpoint is that vestibular therapy and post-concussion rehabilitation can look kind of similar. So if we encounter a patient that needs this type of vestibular therapy, we do have the training to kind of walk them through that process, or at least educate them on the guidelines for what the rehab protocols might look like, and how long it might take to see some improvements. These are my references, and thank you very much for listening.